So at this meeting, we're presenting the updated analysis of KEYNOTE-199, which is a large phase 2 study using the PD-1 inhibitor Pembrolizumab in men with advanced prostate cancer. We initially presented this in ASCO last summer, and the analysis at this meeting is the update. So this was a study with 258 patients with metastatic castration-resistant prostate cancer. They had to have failed a novel hormone therapy as well as up to one taxane chemotherapy. And then these patients were given therapy with Pembrolizumab as a monotherapy, so single agent Pembrolizumab at a dose of 200 milligrams intravenously once every 3 weeks. There were 3 cohorts. Cohort 1 was patients with soft tissue metastatic disease that had PD-L1 positive staining by immunohistochemistry. Cohort 2 was patients with soft tissue disease with PD-L1 negative staining. And cohort 3 was patients that had bone disease without any biopsyable soft tissue disease. 100 patients in cohort 1, 100 patients in cohort 2, and 58 patients in cohort 3. The primary endpoint was objective response rate in the soft tissue lesions for cohorts 1 and separately for cohorts 2. So the punchline is that the objective response rate in the cohort 1, meaning PD-L1 positive soft tissue metastatic prostate cancer, was 5%. So 5% of patients had a tumor shrinkage that was compatible with the RECIST definition. And in cohort 2, which was the PD-L1 negative soft tissue cohort, there was a 3% objective response rate. In the entire population of patients that included cohorts 1, 2, and 3, and again, cohort 3 was the bone only or bone predominant cohort, there was approximately an 11% PSA response rate defined as a 50% decrease. So what is the bottom line with this study? Bottom line is we are seeing some level of activity of Pembrolizumab as a monotherapy in patients with advanced prostate cancer, but the percentages are low, probably in the 3 to 5% range for objective soft tissue response, and maybe in the 10, perhaps up to 15% range for PSA responses. So what does this mean? I think we have to figure out which patients and which tumors are going to respond to PD-1 inhibitor monotherapy. And secondly, what drugs should we be combining a PD-1 inhibitor with to increase the rate of response from the 5% level, hopefully to the 20% or above level.